Welcome to Up Close, the research, opinion and analysis podcast from the University of Melbourne, Australia.
I'm Jennifer Cook. Thanks for joining us. How do you help someone who's been pushed to the limits of their endurance? Someone who's seen and felt things that have wounded their psyche so deeply they can no longer relate to those close to them, let alone function in the normal world. Welcome to Up Close and the second of our two-part series on post-traumatic stress disorder, or PTSD. In our first episode, we learnt about this debilitating condition and the different ways it manifests in individuals and across cultures. Today, we consider the treatment as well as some of the politics surrounding the most prevalent mental health disorder in Australia and one that affects millions worldwide. Mark Creamer is a Professor of Psychology, Department of Psychiatry, University of Melbourne, and Director of the Australian Centre for Post-Traumatic Mental Health. He's joined by Associate Professor Meaghan O'Donnell, who is Director of Research at the Centre, and they will bring us up to date with not only the latest research findings, but also the best way to help those with this debilitating disorder. Thank you so much for joining us again.
It's a pleasure, Jenny.
Hi, Jenny. Now, as I said in our first episode, we talked about the diagnostic aspects of PTSD. How do we decide what it is? Now I'd like to talk about what we do with it. How do we treat people with this disorder? Meaghan.
Well, if we think about what kind of symptoms we see in PTSD, we see intrusive memories and we see high levels of avoidance and we see high levels of arousal. So treatments that tend to address each of those clusters of symptoms. So the first thing we will do with someone is really stabilise them, make sure that they have some strategies in order to manage their high levels of anxiety and distress about these intrusive memories that they're experiencing. And then we would look at the avoidant symptoms that they're experiencing. So people with high level of avoidance, what they're trying to do here is trying to avoid the memories of the event. And when we think about our theories of PTSD, we think that one of the reasons that these symptoms don't dissipate over time, these intrusive memories don't dissipate, is because these people have very, very high, they're very good at avoiding reminders of the event. And so that means these intrusive memories aren't kind of emotionally processed.
I see. So instead of dealing with them,
that's right.
It makes it worse by not dealing.
That's right. So they're not dealing with it emotionally. And so because they're so good at avoiding, and it seems to work because, by avoiding it, they don't get the memory. So they think, oh, that's a great idea. But what we think happens is they don't emotionally process the event. And so therapy is really about emotionally processing the event. And so when I talk about emotionally processing these intrusive memories, one of the evidence-based practices is prolonged exposure. And that's where we help someone to, in a very safe environment, go through the traumatic event in a very detailed, descriptive way. And so they basically fill out all the details of the event. And the idea is that by going constantly over the traumatic event, they habituate or they kind of get used to what their experience was. In that context, they're emotionally processing it. And as a result, the hyperarousal symptoms drop off and their avoidance drops off over time as well.
I can't help but think how incredibly confronting that would be for someone who has been coping by using avoidance, thinking they're coping, and at what stage they would have had to have got to even ask for that help in the first place.
Absolutely right. And I guess the point is that they're asking for help because their avoidance is no longer working, because the images are continuing to intrude, the nightmares are coming and so on. And so they recognise that the avoidance may have worked for a while but isn't working anymore. It is difficult, and as therapists we need to recognise that and spend a lot of time with people explaining what's going to happen and reassuring them and making sure that they recognise that they're in control all the time. We're not going to allow them to be overwhelmed and so on. We tend to call this exposure, prolonged exposure. And the analogy with someone, for example, the very simple end of the spectrum is someone who's very frightened of spiders, so spider phobic. And the way we treat that is by very gently introducing them to spiders, a small spider, the other side of the room, and so on. And I talk to my clients, my patients, about exactly this, because that's what we're doing, the memory, that the memory is your spiders, your frightening thing, and we're going to help you confront that memory step by step and a little bit at a time.
Now, of course, human beings are complex creatures. We will find lots of ways of coping and dealing and avoiding, as you've just said. And we know that PTSD doesn't happen in isolation, and people can tend to cope by self-medicating, can't they? Could you explain to us a bit more about that, Meaghan?
Well, we do see a lot of comorbidity with PTSD. So it does occur in the context of lots of other disorders. So substance use disorder is a typical one. Often you find this with men who develop post-traumatic stress disorder, that one of the ways they cope with these very intrusive, distressing memories is by self-medicating, so using alcohol or other substances. And so in terms of therapy or intervention, we need to address the substance use disorder in addition to the post-traumatic stress disorder.
And of course, the substance use often has a kind of cultural, subcultural context as well, that in many subcultures, again, some of the more male-dominated professions, the idea of going down the pub and having a few beers is kind of part of the culture, and that's the accepted way of dealing with these things. And so that behaviour can then start to become entrenched and become quite destructive in the longer term as people use it to manage symptoms and to mask the symptoms of depression or PTSD. And of course, the dilemma is that the alcohol is serving a purpose in the sense of helping them manage the symptoms. So you can't take away that crutch and leave them with nothing. And so the idea of working with substance abuse and PTSD is very much to do it concurrently, to work with the two together. Because when you get on to the aspect of confronting the memories and doing the painful work of treatment, it's really important that they're not using alcohol as a way of coping with that. So we do a lot of the symptom management stuff, helping them to manage anxiety, manage the painful feelings first, while we reduce the alcohol use and we get the alcohol under control, and then we can move on to do the memory work, which is the main therapeutic ingredient.
As I said before, PTSD is comorbid with a whole pile of other disorders. So depression is one, up to 70% of people with PTSD will have depression as well. So again, it makes a very complex picture in terms of teasing out some of these issues for therapy or for psychological interventions.
If I could just go tangentially a minute, because it's kind of interesting. The area that gets a lot of interest at the moment is something called chemoprophylaxis. In other words, can we prevent PTSD by using drugs? And there's some interesting research, albeit opportunistic kind of research, that suggests that people who've had a few drinks at the time of the trauma do better, because their level of arousal is lower, they're not so frightened at the time, and they end up doing better. And of course, when you think about it, that's got a long historical perspective, hasn't it? Because before people went into battle, they'd have a tot of rum or whatever. My grandmother used to say, if you had a shock, you have a brandy, So it's kind of got a long history. During or immediately after the trauma, the alcohol might help a little bit. But of course, then as time goes on, it becomes more and more unhelpful, more and more destructive.
Insidious.
Insidious indeed, yeah.
This is Up Close, and we're coming to you from the University of Melbourne, Australia. I'm Jennifer Cook, and our guests today are Meaghan O'Donnell and Mark Creamer, and we're talking about post-traumatic stress disorder. So, Meaghan, what are some of these evidence-based treatments?
So I mentioned prolonged exposure, and that's very good at addressing these intrusive memories. Cognitive behavioural therapy is also very useful, especially if it does have this trauma component. Cognitive processing therapy is another form of cognitive behavioural therapy that's particularly useful for PTSD as well. And then the third treatment modality is EMDR, that's eye movement desensitization and reprocessing. And this is a series of techniques where people move their eyes, and it seems to facilitate reprocessing the traumatic memory. Though the Australian PTSD treatment guidelines suggest that it's best paired with some prolonged exposure as well to make it most effective.
The reason that Meaghan is able to talk like that is because we now have a substantial body of research evidence, and we have in a couple of countries what we call systematic reviews of the literature that allow us to combine many studies together and to determine on the basis of those many studies what the treatments of choice are. And the two big ones, I think, if people are interested, are the National Institute of Clinical Excellence in the UK, that was called the NICE guidelines, and also the NH and MRC guidelines here in Australia that are available from our website. So these outline, as Meaghan said, the first-line treatments of choice, which are the trauma-focused psychological treatments, and also the second-line treatments, which are the pharmacological treatments. And here we're looking people won't be surprised to know the new generation antidepressants, the SSRIs, the selective serotonin reuptake inhibitors, which are called antidepressants, but really they're kind of brain drugs because they work for so many different disorders. But they are the treatment of choice from a drug perspective. And very often, of course, we see a combination of someone perhaps getting both psychological treatment and pharmacotherapy, or in situations where psychological treatment is not available, perhaps there aren't trained practitioners and so on, then medication can be very useful. So both are important components of treatment.
Mark, could you just explain to us a bit more about the drugs? You said they're not strictly antidepressants, more brain drugs.
Well, of course, there's a lot of debate about why these drugs actually work, but they are working on something called neurotransmitters, which are chemicals in the brain that take messages around. And the assumption has always been that several disorders, but particularly depression, are a function of the fact that there is a shortage, if you like, of these neurotransmitters. And so the SSRIs are one approach of trying to increase the amount of these chemicals in the brain. But what's interesting is that although they were designed for depression, the more they're used, the more it's clear that they're actually having effects on other conditions, certain anxiety disorders, even certain addictive behaviours, but also PTSD. And there are a number of advantages to them in terms of their ease of use and in terms of the broad spectrum of their influence. So not all the three clusters that Meaghan talked about, the intrusive memories and the avoidance and the arousal, all seem to benefit from this drug. But I would emphasise, I would like to come back to where we started, and that is that these drugs are still a second-line treatment. The treatment of choice is unquestionably a trauma-focused psychological therapy. And that makes sense because it is about, whatever terms you want to use, it's about coming to terms with what happened, it's about confronting what happened, it's about working through what happened. It makes sense that this is a psychological process that survivors have to go through.
We've spoken about the person suffering from PTSD and what they go through and how it may best be treated. I'd like to talk a little bit now about the impact on the people around them, on family and friends. How does it affect them and what kind of support do they need?
Well, this is a disorder that can have enormous impacts on loved ones, on family and friends and so on. Again, if we think about the symptom profile that Meaghan was talking about, part of it at least is characterised by social withdrawal, by shutting down the system, by becoming emotionally numb and withdrawn and so on, but also combined with being very volatile, angry and aggressive and irritable and so on, and jumpy. And so for family members to have to live with this change in their loved one can be very, very difficult indeed. And unfortunately, we do see a large amount of relationship breakups and family dysfunction in families of people who have PTSD.
And there has been some evidence, hasn't there, of children of sufferers from PTSD and the effects it's had on them, Meaghan?
Well, we don't know if it's necessarily about the PTSD itself that makes the children of sufferers particularly vulnerable, but we do see evidence of mental health problems in the children of people who have PTSD, but this could be a function of having a mental health disorder. So it could be that people who have depression, that impacts on their children as well. We need to do a lot more research around teasing out whether there's something specifically toxic to children if a parent has PTSD, or whether it's you see these kind of problems across the whole spectrum of mental health disorders.
It's an interesting thing that a lot has been written about, this concept of transgenerational impact of trauma. And of course, Holocaust survivors are one obvious group. Veterans are another obvious group where a lot of this work has been done. And it's very complicated. There's no clear answer at the moment.
It seems at the very heart of this PTSD is the issue of vulnerability. And Meaghan, you've got some really interesting statistics about those who develop PTSD after a car accident.
That's right. So a lot of my research looks at injury survivors. This is a particularly interesting group because injury occurs so frequently. Severe injury is one of the biggest causes of PTSD because it happens so frequently. So even though someone is more likely to develop PTSD after a rape, severe injury is one of the biggest causes of PTSD. So in terms of the kind of things that contribute to someone developing PTSD after a severe injury, such as a motor vehicle accident, there's characteristic that the person brings in to the trauma itself. So that Mark talked about this in our last episode about those kind of pre-morbid vulnerabilities. But then there's the issue of the event itself that contributes to their vulnerability. And then there's aspects about what happens after the event. And I think we could just tease that out a little bit more in terms of what keeps someone safe or what increases someone's resilience against developing, say, PTSD.
And certainly this feeling of safety in the aftermath. I mean, we're recording this program just a matter of weeks, really, after a massive earthquake in New Zealand, in Christchurch. And one of the things that we're hearing is the extent of the aftershocks, that frequently they're experiencing aftershocks. And one can't help but wonder what that does for people's feeling of vulnerability and fear of a recurrence and so on. And that's a very clear example from the natural disaster area. Of course, we know the same thing happens in areas like assault, where people are in dangerous situations, fear of being assaulted again, or in military deployments. And so that sense of safety and that sense of being able to actually start the recovery process is crucial, in terms of predicting adjustment.
And we know that social support is a very, very protective factor. So people with good levels of social support are very, very protected. Now, in situations, as you say, Mark, where the whole community has been affected, then people's social support aren't necessarily available to help someone through the event because those people are suffering as well. So this is when we start getting all those community impacts of surviving a natural disaster, which makes it particularly difficult.
We saw that here very vividly in Victoria with the bushfires in 2009, where we had whole communities affected by fire.
Exactly right. And so the recovery operation following those bushfires, and indeed we've had some bad floods in Queensland not long ago and so on, the recovery operation needs to address a number of different levels, but the community level, the broad whole population that's affected, it needs to address the people with low-level problems who might be going to see their GPs and so on, and it needs to address those with more severe problems, the minority, who will need specialist mental health care. And so we develop a framework and a way of responding to these kinds of disasters that takes those three levels into account.
This is Up Close, coming to you from the University of Melbourne, Australia. I'm Jennifer Cook, and our guests today are Meaghan O'Donnell and Mark Creamer. We're discussing post-traumatic stress disorder. Now, can you tell us about the particular challenges that soldiers face in the military? So namely, it's this prolonged exposure to trauma.
There are a range of factors associated with military service and particularly deployment to a dangerous area, combat zone or whatever, that are very, very high risk. And one of them, as you mentioned, is the very long duration, during which time often the person can't afford to relax. So maybe 6, 12, even the American deployments, sometimes even longer than that, of constantly being on alert, constantly being on the lookout for signs of danger. And, there's some evidence to suggest that this lengthy exposure actually results in a kind of recalibration, if you like, of the nervous system that is very difficult to reverse sometimes when people return. So it can have quite long-lasting effects. And, of course, the complexities of war and combat and the horrible, horrible things that happen, a lot of factors can make it very difficult. This is something that our armed forces around the world need to take account of. And I have to say that in recent years, they've come a long way in recognising and trying to do something about the potential mental health effects of these deployments.
You used that expression, recalibration of the nervous system. Could you just explain that a bit more? What are you talking about?
The research evidence is still equivocal, but the theory would be that if someone spends so long with their their threat detection and response system on high alert for a very long period of time, then it becomes difficult to switch it off. And so they come back to the hopefully relatively safe cities and towns that they live in with their families, and yet they're still on that state of hypervigilance and it just can't turn off. One of the things we see is in many people is the sort of adrenaline junkie, the idea that they constantly have to find things that are frightening, drive fast, do dangerous activities, thrilling sports and so on, which may be a way of dealing with this constant hyped up state. So we need to spend a lot of time teaching people to readjust back into society, back into Australia after the deployment. And a lot of that is about reducing arousal. It's about being able to bring the nervous system back down to a level that's appropriate for the level of threat here in Australia or in Europe or wherever it is.
And there are some people, and there's been studies done on people who seem to cope very well with prolonged periods of high stress, say in a military situation. Tell us a little bit about that.
Well, I think the point you're making really is that there are enormous individual differences. Yes. And what's good stress for some people is bad stress for other people. And really what that highlights is the challenge that certainly the military around the world is facing in terms of trying to select people, trying to determine before people join who's going to be able to tolerate high levels of stress for long periods of time. But I have to say it's a bit of a challenge. We've got a long way to go before we can reliably do that, I think.
And also I can imagine a scenario where you have someone who appears to cope with stress very, very well. So you keep putting them in that situation with the stress. How good is that long term for that person? Do they just have a longer lead time? Will they eventually break down? Are we just putting too much on them?
Well, I think that's the question everybody's asking. Does everybody have their breaking point? And yes. I suspect they probably do. Certainly in military defence forces around the world, there are certain roles that are very much in high demand. And so there are certain elements of the defence force that keep getting deployed because they need to be deployed all the time. And we need to be asking the question, yes, OK, these guys are pretty resilient, but is there going to come a point at which this gets too much even for them? So I think it's incumbent upon the defence forces to be really closely monitoring the mental health and well-being of these forces that are deploying regularly to make sure that we can identify the problems very early on and intervene before major damage is done.
Now, PTSD is a very politically charged issue, isn't it, Mark?
Because it has massive implications often for governments and for big institutions like our defence forces and our emergency services and so on, and how government should respond. It is very politically charged. It can be a very kind of emotive issue about which people have very strong views. And of course, I think we talked about this last week, that it's inextricably tied up sometimes with issues of compensation and what that might mean. And I might get Meaghan to chat about this because it's more her area than mine. But there's a lot of interest now, isn't there, in compensation and recovery from trauma.
And indeed, in our first episode, we talked about how it was actually called, compensation
neurosis. That's right, yeah.
And the issue with PTSD that's particularly interesting is that it's one of the only psychiatric disorders that the etiology is built in to the diagnosis. That is, that someone has to have a traumatic event. And it's one of the reasons that lawyers like it, because if someone develops depression after a traumatic event, you can't say, well, this person developed depression because of the traumatic event, because that's not in the diagnosis. But PTSD, you have to have the traumatic event to get the diagnosis in the first place. So it's because it's linked to the trauma, then lawyers find it very easy to then say, well, therefore we can get compensation because this person has this psychiatric disorder because of the traumatic event. It's kind of neat and tidy, whereas depression or, it's a phobic disorder cannot be necessarily intrinsically linked to the traumatic event.
The big fear, of course, is that compensation will make people stay sick. And that's the big question. Are people staying sick because they have to hang on to their illness in order to get compensation?
There is an aspect of that. And also the other fear is, are there processes that in order to get compensation you have to go through that make it difficult for someone, especially someone with a psychiatric illness, and therefore that contributes to their stress and therefore that's why it's problematic. It's probably more consistent in the workers' compensation literature that it does seem that the compensation process leads to worse outcomes. But in terms of other compensation schemes, so across all compensation schemes, I think the question is still out there, and we need to get much better at teasing out some of the issues where compensation may or may not impact on someone's recovery. Genuinely, compensation agencies are very keen to identify what is it about their processes that might make it difficult for someone, and therefore, can we change those processes in order to facilitate someone's recovery?
Because we do have some preliminary data, as you'd expect, that the more adversarial it is, the more people have to fight, the worse the outcomes. That's kind of what you'd expect. So maybe third-party insurers and so on can learn from that process and reduce the adversarial nature without necessarily feeling that they're giving away the safeguards that they need to keep in terms of making sure they're compensating people who genuinely need it.
I'm trying to imagine how someone who's suffering from PTSD and all the raft of nightmare symptoms that they're going through to be then faced with a bureaucratic mountain of paperwork or minefield to get through.
That's right, and numerous medical assessments where they have to repeat the traumatic event over and over again to someone who they don't know, and it's not a safe environment. So PTSD is one of these particular disorders where those kinds of processes are not very, are very detrimental for someone.
I'd like to ask both of you, based on your research, if you could summarise for us. Tell us, what are some of the risk and the protective factors of PTSD? What leaves us open to it, and what can we do to protect ourselves from it or recover from it?
Well, one of the protective things we haven't talked about is what we see in occupations that are exposed to trauma. So our emergency services, we've spoken about the military. And we also see this with media personnel who often are at least witnessing traumatic events. And what the research is showing us is that group or unit cohesion is very, very protective. And what that means is if people are getting support from their work environment, so let's say there's good support in an ambulance unit, or the fireys have a really good unit that's very emotionally supportive, then that is protective as well. So there are things that, especially for high-risk occupations, that can be very protective and that the organisations can do in order to look after their work employees.
But to take that one step further, because social support is so important, we often have to teach people how to use it, which is kind of a tragedy, really. But we talk about, looking after your mates. You look after your mate if they get shot or if they get injured or whatever. You don't think twice about it. You've got to look after your mate if he's suffering a psychological injury, or he or she is. So teaching people how to do social support is very important. I think also that we've talked a number of times about this issue of arousal being very hyped up and on edge. So teaching people arousal management, how to keep their own level of uptightness low, can be an important factor, we think, in terms of protecting them when they go into very difficult situations.
Thank you both so much for talking us through this complicated disorder, but also the implications of that, what it's like to suffer from PTSD and try and move through day-to-day life. Thank you, Meaghan, and thank you, Mark.
Thank you, Jen.
We've been speaking with Professor Mark Creamer and Associate Professor Meaghan O'Donnell from the Australian Centre for Post-Traumatic Mental Health about the issue of post-traumatic stress disorder. Relevant links, a full transcript and more info on this episode can be found at our website at upclose.unimelb.edu.au. Up Close is a production of the University of Melbourne, Australia. This episode was recorded on March the 10th, 2011, and our producers were Eric Van Bemmel and Calvin Parham. Audio engineering by Gavin Neighbour. Up Close is created by Calvin Parham and Eric Van Bemmel. I'm Jennifer Cook. Until next time, goodbye.
You've been listening to Up Close. For more information, visit upclose.unimelb.edu.au. Copyright 2011, the University of Melbourne.